Hello, everybody, and welcome to the PT on Ice Daily Show. My name is Christina Prevett. I am one of our division leads in our geriatric MMOA division. And today I wanted to talk to you a little bit about the ins and outs of catheters, more from the catheter placement itself. And what maybe we should know as geriatric clinicians who are working with individuals with catheters about some pelvic health considerations and some of our current guidelines around the use of catheters. I'm actually doing a virtual ICE, which is our monthly subscription to different content areas on special topics specific to geriatric pelvic health next week. And one of the things that we're really going to deep dive into is catheterization. So this is just kind of like a teaser to that talk as well. When we are talking about catheters, there's three types of catheterizations that are oftentimes discussed in our literature. The first one being an indwelling catheter, where there is a tube that goes up the urethra to insert into the bladder and help to evacuate the bladder. There is intermittent catheterization, which oftentimes happens in the instance of neurogenic bladder or neurological disease, where something around the mechanism to void your bladder makes it so that you end up not being able to evacuate your bladder and urine cannot go through. Like the detrusor does not take that signal to contract the bladder that allows urine to leave the body. And therefore, you get external help where a person will do it independently in order for them to be able to pee. And usually this is done on a schedule. That is a whole other area of pelvic health. And then what we have been seeing more commonly around hospitals in the United States is an external catheter called a periwick. And what the external catheter is trying to do is to avoid some of the complications and issues that we are seeing right now with indwelling catheters, which we're going to talk about. Most of the time, individuals are using catheters post-operatively. Like that's the most common. When individuals are under general anesthesia, a catheter is placed in order for obviously the bladder to function while under anesthetic so that the surgery can proceed. Most of our post-operative guidelines through the NICE and through some of our surgical organizations advocate for a short duration. And if it's pelvic floor surgery, it's considered less than 7 days. If we're thinking about orthopedic surgery, ideally it's a day or less. So basically, once individuals have recovered from surgery, we are trying to remove those catheters in order to prevent any catheter-related negative events or adverse events. When we are looking at some of our literature and what maybe many clinicians who are in the acute care setting listening to this podcast are going to recognize is that what this guideline says is not necessarily what is always happening in clinical practice. People are keeping catheters in a lot longer, or people are being catheterized when maybe there isn't the strongest indication to do so, and it can cause downstream consequences. So let's kind of talk about them. Narrowed in to an indwelling catheter, it is possible that urethral injury or pelvic floor dysfunction happens as a consequence of having a catheter in. So the injury itself makes a lot of sense, right? Because you have to place a tube through a very small tube in order to get into the bladder. And if that is not done appropriately, that can lead to urethral injury. That can lead to things like post-micturition dribbling, painful urination with it removed, or other issues with voiding the bladder. From a pelvic floor perspective, what we see is that you end up getting into this habit where you never have to defer urination. So a healthy bladder is individuals who do not worry about their bladder. It does not impact their quality of life. And they are able to defer the urge to go to the bathroom until it is like PRN, until it is convenient to do so. And as the bladder fills more and more, that urge sensation to go to the bathroom heightens until we get to a point where we cannot defer it any longer because our bladder is too full and we need to evacuate. When you have a catheter in, you never really have to defer that urge to go to the bathroom. And so what can happen is that individuals can get into this place with the when the catheter is removed, that they have to retrain their bladder and their mind to be able to defer those urges. And when you have a sudden urge to go to the bathroom that you cannot defer, that is a condition called urge urinary incontinence. And a lot of that is linked to behavioral interventions and bladder retraining. And that would be kind of our next step from a clinician perspective if we had individuals who are dealing with this. So that's kind of centered to the rehab role around the catheter itself. The two other post-operative complications or catheter-related complications that we always have to be on the look for is that the longer that an individual has a catheter in, the more likely they are to have a catheter-related urinary tract infection. And we know, again, as geriatric clinicians, that a urinary tract infection can have a massive consequence on a person's motor and cognitive function. Oftentimes, we're thinking about like the infection itself and treating it with hopefully with antibiotics. But from our perspective in rehab, we also know that individuals with UTIs can see a sudden change in function. And if we are working on discharge planning, that can be a big issue to getting individuals to be able to go home. And then the second thing is post catheterization urinary retention. And so I had mentioned that some people will use intermittent catheterization because there's something that is disrupted in the mechanism where usually when we get the urge to go to the bathroom and we are saying, okay, I am going to void, the smooth muscle of our detrusor in our bladder contracts, our pelvic floor relaxes, and it allows urine to flow through our sphincters in our urethra. They open and bladder flows through the body. With catheterization, again, with potential injury, we can have post catheterization discharge urinary retention, and that could be a complication, one that we are not as directly involved in, but things that can lead to lengthened hospital stay. So that's kind of like center to the pelvic floor. When we zoom out, oftentimes when we have individuals who are on prolonged catheterization, then there is even less reason for them to get up, right? And so I'm also very cognizant of when you don't even have a bathroom break that you need in order to get out of bed, is this going to contribute to hospital acquired muscular weakness, which is an absolutely massive issue in our hospital networks right now and something that we need to be considering. And this is one of those things that's kind of a chicken or the egg because we have evidence that individuals with higher levels of frailty, so those that do not have a lot of resiliency, who are already weak coming into hospital, end up needing catheters for longer. But they're the ones also that are going to be the most vulnerable to any loss of muscular strength because of prolonged bed rest while in hospital, right? And so we kind of have this bidirectional relationship where we are seeing prolonged catheter exposure to those who come into hospital with less resiliency. And then it potentially exacerbates because we're not getting individuals up as much due to the fact that they have a catheter in, that they're not, getting up and saying, I have to go to the bathroom. And so from that perspective, I think it's something in rehab that we have to be mindful of around how do we try to mitigate hospital acquired muscular weakness. We could potentially advocate for removing catheters if we think that it is something that our clients are going to be able to do as part of the rehab team. And then thirdly, what we want to think about is, does this pave the way for functional urinary incontinence? So functional urinary incontinence is when individuals are getting the urge, like their brain is telling them, hey, your bladder is full, but there is something blocking their capacity to go to the bathroom. So that can be cognition. We see this in dementia where individuals may have the urge to go to the bathroom, but that motor planning from I have the urge to go to the bathroom to executing and go to the bathroom can be delayed or non-existent. But it can also be that they do not have the capacity to go to the bathroom on their own because of their functional resiliency. Again, another role for rehab in this space. And so if they have weakened because of catheterization, they may experience more leakage with getting up from the bed, or coughing or sneezing. They may experience stress urinary incontinence, because if your body is weak, your pelvic floor is weak too. And if your pelvic floor is weak and just had an injury because of catheterization, it may exacerbate some of those conditions. And so making sure that we are considering some of these things with functional urinary incontinence on the back end, when individuals are being discharged from their catheter, is things that should be part of our screen, so that we can make sure that we're not missing anything from a rehab perspective in the pelvic health space when we are working with some of these individuals. And so, as I've kind of said, there are known risk factors to having indwelling catheters. And so, what that has done is it has tried to get individuals, or there have been pilot projects where they are looking at external catheters, which is the periwick is a little machine that they put basically in the brief of the individual that they are working with, and it has a little bit of suction. And so when individuals pee, basically the suction is always on this pressure loop. And what happens is that urine passes into the brief, makes contact with that suction, and suctions the urine out of the body. And what this does is it prevents a tube from going into the urethra and leaves everything external to try and avoid some of that urethral injury, and specifically the post discharge, catheter discharge, urinary retention. Our research here is pretty sparse. We still have to do a lot of work to look at, what should be the care pathway of when do we use internal versus external versus intermittent types of catheterization. But I think trying to avoid some of those complications around urinary retention are super valuable. Where that role is for us as rehab clinicians, and is that going to change what we see from a pelvic floor perspective? The jury is still out. And my only caution is that I want to hopefully advocate or have front of mind, that I do not want to use external catheters in order to reduce our burden of putting people to or getting people to the bathroom, because there's always this balance, right? When individuals have catheters, they're less likely to get up, and when they're less likely to get up, they're more likely to get weaker in hospital. And we are like, our main goal, right, as clinicians in the rehab space is two prong. One is to avoid hospital acquired muscular weakness, and two is to get people home. And so that to get people home and discharge plan them, they have to avoid that hospital acquired muscular weakness. And so we want to make sure that we are mindful of our role within this space. I know it tends to be, oh, a person has catheter, we kind of document that they have that and we consider it in our mobility interventions in hospital. But maybe that there is more that we can do, right? Maybe we can step into our role as pelvic health clinicians to help our team to talk about bowel and bladder health, bladder health specifically with the catheter, and step into this space to be able to see how we can help. And if you're working in home health and you have a person who is just discharged, maybe screening for their catheter use and consequences of that catheter, because oftentimes, again, we don't talk about it, and it can be uncomfortable or painful around the penis or the vulva. And that pain, people can say, well, I just had a catheter removed, but there may be something, again, that we can do from a pelvic health perspective as a geriatric clinician. All right. I hope you all found that helpful. If you are in advice, I will talk to you all next week, because it is going to be one of our deep dive topics. If you are looking to see MMOA live, there are only two courses left for the end of the year. Both of them are going to be by me. I'm going to be the lead faculty. This weekend, I am in Mineola, just outside of New York City, New York. So November 2nd and 3rd. My last course of the year is December 7th, 8th. I'm in just outside of Cincinnati, Ohio. And our first course of the year to launch 2025 is January 18th, 19th in Hendersonville, just outside of Nashville, Tennessee. So if you are looking to get your coaching skills in, get lots and lots of lab time, I encourage you to head to ptonice.com and sign up for any of these courses. Additionally, we are going to have a cool new resource coming out very soon. Wait for that announcement, and that will be available for you in the app. Have a wonderful week, everybody, and we will talk to you all soon.